Yes. Good evening, everyone, and I welcome you all to today's scientific session, that is the WIMS Alumni Academic Meet. And today we have a very important topic that is about obstetric anesthesia, tips and training for the tips for the trainees and the practitioners. So we have two eminent speakers, Dr. Kousalya Chakravarti Madam and Dr. Manjula Sudhakar Rao, who is going to enlighten us about the uterotonic agents and anesthesia for the anesthesia practitioner and the cardiopulmonary resuscitation in pregnancy. So I welcome you, madams, and I extend my greetings from ISA Ballari and WIMS. So to the topic, the first topic is the uterotonic agents by Dr. Kousalya Chakravarti. I request Dr. Srinivaslu sir to introduce our speaker. For two eminent speakers. Srinivaslu sir, can you please unmute yourself? You're muted.
Dr. Jyotsna, you Dr. Kousalya Chakravarti or biodata.
Okay, sir.
You have sent me the Manjula Ross. Can you read? Anyway, introduce me.
Can you please introduce Kousalya, madam, sir?
Yeah. Welcome you, madam.
Thank you, sir.
Doctor.
Okay, you Jyotsna?
Yeah.
Jyotsna?
Dr. Kousalya
You're audible,
Chakravarti.
sir.
Yeah, biodata Kalisila. Yes.
Okay. What I will do, Dr. Jyotsna, I will read out.
Manjula Sudhakar Rao Kalisidira. Neeve helpude. You can introduce her and can stop.
Dr. Jyotsna?
Hear you, sir.
Yeah, can you hear me?
Yes, I can hear you.
Yeah, okay, shall I have the privilege of introducing Dr. Kousalya?
Yeah,
Yes,
please.
sir. Yes, sir. Thank you, sir.
Okay, right. I think, am I audible?
Yeah, you're audible.
Yeah, no, I had some network issues. I think I didn't listen to some of the conversations.
Yeah.
That was the issue.
Yeah.
Yeah, it's a delay in opening. Yeah, Madam is MD Anesthesia and she has fellowship in obstetric anesthesia as well and a PhD in anesthesia. She is currently Professor and Head of the Department of Anesthesia at the Government Medical College, Jangaon in Telangana. And she is also a consultant at Swapna Healthcare, Hyderabad. So her areas of interest are obstetric anesthesia and obstetric critical care. And of course, she is a provider in ACLS, ATLS, FCCS, CTLS also, and Inspector FCCS Obstetrics, and faculty in WFHS Safe Obstetric Program. And she was a subspecialty editor and peer reviewer for IJA, and she has about 18 publications and has contributed chapters on endocrine diseases and drugs in ICU. Welcome, madam. Thanks for accepting the invitation from the work group and ISA Ballari. You can please start your presentation. Thank you.
Thank you so much, sir, for your kind introduction.
Madam, just a moment. I will request everybody to silence for a moment.
Yes, sir.
I will see. I try to deal with that.
Can I start, sir?
I just try to mute everybody, then we'll start. Because once started, the speakers will not be happy with disturbances. Just a moment.
Yes, sir.
Yes, unmuted. Okay. Okay, thank you. I think it's clear now. Madam, please you can start.
Yes, sir. Thanks a lot, sir, for giving me this opportunity. It's my pleasure. And good evening, everyone. And today I'm going to talk about a dry topic, that is uterotonic agents. And among the uterotonic agents, the most commonly used agent is oxytocin. Thank you. It's not changing. Yeah. So, here we have a second gravida, para 1, live 1, live 2. She was previously twins gestation, low risk pregnancy now, and she doesn't have any comorbidities. The labor was induced with Foley's, augmented with oxytocin since 12 hours, and she was taken up for emergency LSCS in view of non-progression of labor. Oxytocin was given after the baby delivery. The patient had atonic PPH. The oxytocin dose was increased to from 20 units to 40 units. Still, the patient was having atonic PPH. And the second case is third gravida, para 2, live 2, past dates, elective LSCS. She's the third gravida. Oxytocin 10 units was given and in 100 ml over 10 minutes. And she didn't have any PPH and the case was uneventful. So why oxytocin acts in some patients, why it doesn't act? Where did we go wrong? Is it wrong with the patient, with the drug, with the dosage, with the time of administration, or with the mode of administration? And how to identify who needs more amount of oxytocin, and who needs lesser amount of oxytocin. So among the 4 T's of PPH, the tone is the one which is taken care of by the oxytocic drugs. That is, we are not calling them as oxytocic drugs nowadays. It is totally known as uterotonic drugs. It increases the tonicity of the uterus. So what are the uterotonic drugs? There are two lines of drugs. First line is oxytocin and carbotocin, and the second line of drugs are methyl ergometrin and the prostaglandins, that is Carbocrust and Misoprost. Oxytocin is a drug is produced by hypothalamus and is secreted by posterior pituitary. It was discovered by Henry Dale and first synthesized in 1953. The oxytocin acts by the oxytocin receptors. The oxytocin receptors are there in the oxytocin in myometrium as well as deciduea, and the oxytocin acts on the oxytocin receptors, and then acting on the phospholipase C, it increases the intracellular calcium, intracellular calcium content, and ultimately it causes the myometrial contraction. So we know that there are oxytocin receptors. What are these oxytocin receptors for? As you can see here, the oxytocin number of the oxytocin receptors increases from 172 to 3,468 when the patient is in early labor. So this early labor is in the patients who are for elective cesarean section, and this advanced labor is in those patients who have come for emergency cesarean section. So you can see here that while the elective cesarean section oxytocin receptors are in 3000s, the emergency cesarean section oxytocin receptors are in 200s. So why is this decrease in the oxytocin receptors? This is known as oxytocin receptor desensitization. That is, when the patient is exposed to oxytocin for a long time, especially higher amount of oxytocin or prolonged duration of time. So in such conditions, the oxytocin receptor concentration decreases. So this decrease is more seen during oxytocin augmentation or oxytocin-induced labors. So this is the lab of Dr. Balki, Mrinalini Balki, who does a lot of laboratory researches in oxytocin receptors and the oxytocin drugs, uterotonic drugs. And she has taken myometrial samples from 62 women, laboring women, before they received the oxytocin. And then they have pre-treated these samples. They have taken slides of the myometrium and they pre-treated this with oxytocin. oxytocin and then washed with saline, and they have seen the sensitization of these receptors in terms of uterine tonicity, the myometrial tonicity augmentation, and the area under the curve of the contraction. So what they found is whenever there is a oxytocin pre-treatment is there is oxytocin receptor desensitization. So what happens with oxytocin receptor desensitization? Why are we discussing so much about these oxytocin receptors? Whenever there is a desensitization of the oxytocin receptors, those receptors are no longer sensitive to the oxytocin drugs, the oxytocin that you are giving to the patient. So what happens? This patient who has been induced with oxytocin, they go into dysfunctional labor. And this becomes a failed induction or non-progression of labor. When there is non-progression of labor, the patient will land up in cesarean section. So in cesarean delivery, since the patient has oxytocin receptor desensitization, it will not respond to the oxytocin which you have given. So there will be uterine atonicity. Ultimately, this uterine atonicity and this non-responsive to the oxytocin that you are giving and the prolonged labor and the dysfunctional labor, ultimately it leads to PPH. So is there anything like oxytocin receptor resensitization so that we can resensitize these desensitized oxytocin receptors? That is known as the recovery time. A recovery time is when you stop oxytocin when you stop giving oxytocin to the patient, when you have decided that this patient is going for a cesarean section. So how much is the receptor time? That is recovery time of the receptors. That is known as desensitization of the oxytocin receptors. This is the study done by that has come in 2017 in Canadian Journal of Anaesthesia, where they have analyzed 490 women, and they have analyzed whether these patients have become more responsive when they stop the oxytocin, giving oxytocin to the patients when they have decided to take the patient for a cesarean delivery. They have found that the average time is average recovery interval is 99 minutes, and they have found that every 10 minutes increase in the recovery time decreases the blood loss by 10 minutes, 10 ml. And they have found that in the morbidly obese patients, there is a higher amount of estimated blood loss than in the normal patients. So definitely there is a resensitization time. So whenever you are taking any patient for a non-progression of labor, especially if the patient has been augmented with oxytocin, give an interval of at least 60 to 90 minutes if it is possible. That is, if it is category 3 cesarean section, we can do that. And so coming to the safe administration of oxytocin for the obstetric patients, when will we administer oxytocin? That is either prophylactic, that is to prevent the uterine atonicity, or management to treat the uterine atonicity. How is it given? It is given either as a bolus, either as an infusion, or a bolus plus infusion. So I am emphasizing more on oxytocin because oxytocin and Carbotosin are the first line uterotonic drugs. So I am emphasizing more on oxytocin. So this is the recent study where they have found whether to give oxytocin IV or IM, because WHO has said 10 units of oxytocin IV or IM. So what should we do? So they have taken 7,734 women in the study where they have received same 10 units of oxytocin and divided them into IM and IV group, and they have found that the severe PPH rate, incidence of blood transfusion, and need for the manual removal of the placenta were more in IM group, whereas the use of uterotonic agents, additional uterotonic agents, that is second line of uterotonics, and the incidence of serious maternal morbidity and the adverse effects are no different between two groups. So they concluded that if at all we have an access, IV access, it is always better to give oxytocin by IV route. So what is ED90 for oxytocin? That is in 90% of the patient, 90% of the cases, the oxytocin will produce a good amount of uterine tonicity. So first study was done in 2004 by Carvalho et al., where they have found that for elective cesarean sections, the ED90 is only 0.35 international units. So why did they do this study? They did this study because in those days, they used to give 40 units of oxytocin in 1 liter of crystalloid solution, and they used to run it at the full flow. So when the patients were having 40 units of oxytocin, there was a lot of problems with oxytocin, especially the retention, water retention, which is causing a decreased urine output and also leading to convulsions and cerebral edema, especially in patients who are having hypertensive disorders of pregnancy. So Kousalya et al. First studied the elective oxytocin, ED90 of oxytocin in elective LSCS, and surprisingly, it was found that the ED90 is only 0.35. Instead of giving 10 or 20 units of oxytocin, we can as well give 0.3 units of oxytocin. So in 2021, the Pesca et al., they have found that when the patient is morbidly obese, this ED90 from 0.35, it increases to 0.78. That is almost, it doubles. So there is no fixed dose of oxytocin for everyone. ED90 of oxytocin differs from patient to patient. And in 2006, Balke et al. Have found that if we go for non-elective cases, like in cases where there is a non-progression of labor, the ED90 of oxytocin increases 10 times. It becomes from 0.35, 0.3, it becomes 3 international units. So this may be because of the desensitization of the oxytocin receptors, which we have found. And Pesca et al. In 2022, this is a recent study where they have taken only twin pregnancies and they have calculated the ED90, and they have found that the ED90 is almost 10 times, that is 4.38. So whenever we are giving oxytocin to the patient, we have to ideally see whether this patient requires more amount of oxytocin or not, and then we need to decide. So what is this rule of threes? This rule of threes has become very, very famous. And actually what this rule of threes is, you give 3 units of oxytocin as soon as the baby is delivered, wait for 3 minutes and let the obstetrician assess the tonicity of the uterus and give the second dose of second 3 units of oxytocin bolus, and then wait for another 3 minutes and give another third dose of oxytocin bolus. If by this time the uterus doesn't retract, then you have to give a maintenance dose of 3 international units per liter at a rate of 100 ml per hour. And then if the uterus doesn't retract with this also, then you have to go for the other 3 options, that is Methogen, Carbocrust or Misoprost. This is known as rule of threes. There are plenty of studies on oxytocin, how much oxytocin should be given, when it should be given, how it should be given, where it should be given. So all these studies, the thousands of studies, almost 80% of the studies were done by anesthetists. So still there is a confusion about the dosage of the oxytocin, how much of oxytocin has to be given at what time. So the official body recommendations are there, and of this I have highlighted 4 official bodies, that is RCOG of UK, which has come out with the consensus that in 2016 that oxytocin 5 units has to be given by slow IV. In UK they used to give as a bolus. Oxytocin is given as a bolus 5 units. So now in 2016 RCOG has said it has to be given by slow IV. And ACOG, the ACOG used to give 20 to 40 units of oxytocin, and now they say oxytocin has to be given as a bolus or infusion, and it is 10 units. And WHO has said oxytocin has to be given either 10 units IM or 10 units IV. So optimal dose of oxytocin in cesarean section, this is the international consensus. Instead of having different official body statements, the international consensus statement of using oxytocin drugs during uterotonic drugs during cesarean section. So they have said that if you give bolus of 1 unit of oxytocin immediately after baby delivery, and you can start the infusion at the rate of 2.5 to 7.5 international units per hour. So this is a combination of giving a bolus along with a maintenance dose. And if required, after 2 minutes, if the uterus didn't retract, then you have to give additional 3 international units. But this has to be given more than 30 seconds. That is for at least 1 minute. Or you have to take at least 1 minute to give this 3 international units. And then if then even with this 1 plus 3 and the infusion, if the uterus is not retracting, then you have to think about the second line agent early, and because this may lead to uterine atony. And then you have to review the patient's clinical condition before discontinuing the infusion, and they recommend the infusion to be continued for at least 2 to 4 hours into the post-operative period. Suppose the patient comes with the intrapartum cesarean section, that is non-elective cesarean section, then the oxytocin requirement will be around 3 international units over more than 30 seconds. And then the infusion will be 3 times, that is 7.5 to 15 units per hour. And this has to be continued for at least 2 to 4 hours. So what are the adverse effects of oxytocin? The oxytocin has got many adverse effects. It can cause anaphylactic reaction, though it is very rare, and it can cause postpartum hemorrhage, though it is given as a prophylaxis for PPH. Oxytocin itself can cause PPH mainly because of desensitization, and it can cause cardiac arrhythmias, both bradyarrhythmias and tachyarrhythmias, and fetal afibrinogenemia, fatal afibrinogenemia. That is, the oxytocin itself can cause the patient to go into DIC, and nausea, vomiting, and premature ventricular contractions can be there, and severe water intoxication because it has got an antidiuretic effect, which can in turn cause convulsions and coma. So why oxytocin fails? Oxytocin can fail because at the level of the manufacturer itself, poor quality, and it is not a good pharmaceutical ingredient. So the quality of the oxytocin drug itself may be poor. And second is lack of sterile manufacturing environments, low quality manufacturing process. And the last and very important thing is lack of temperature control, either in the supply or in the cold chain or at the health facility. I mean, till almost the last 10 years, nobody knows that oxytocin has to be stored in fridge. None of the PHCs oxytocin was stored in fridge. So it is not exactly not the time it is got exposed. It is also around the duration, not only the temperature it got exposed, it is also the duration. So it is the cumulative temperature that oxytocin vials ampoules and vials got exposed to the temperature that causes the quality of the oxytocin to degrade. So now, because the oxytocin is heat sensitive, we got that heat stable Carbotocin. Carbotocin is a long-acting synthetic analog of oxytocin, and it binds to the oxytocin receptor similar to oxytocin, and it causes rhythmic contractions, increased frequency of existing contractions, and increased uterine tone. So what is the difference between the oxytocin and Carbotocin? Oxytocin can be given IV, and when it is given IV, it acts almost immediately. And when it is given IM, it takes 3 to 7 minutes, but it has got a long-lasting effect, and the half-life is only 1 to 6 minutes. Whereas heat-stable Carbotocin, when you give IV, it causes uterine contractions within 2 minutes. It lasts for 6 minutes, and usually we don't give it IM because it takes longer time to act if we give IM, and the rhythmic contractions last for 120 minutes. The main thing is the half-life is 40 minutes. So if you give Carbotocin, you need not give an infusion of Carbotocin again because the half-life is longer time. And coming to the storage and transport, as I have already told, oxytocin has to be protected from the light, whereas Carbotocin can withstand the long temperatures. And coming to the clinical conditions, oxytocin can be used for induction, augmentation of labor, and also prevention and treatment of PPH. Whereas Carbotocin can be used only for prevention of PPH. It cannot be used for induction and augmentation of labor, and definitely it cannot be used as a treatment for PPH. So the dose of Carbotocin has been described as 100 micrograms as bolus over 1 minute. So when they said 100 micrograms as a bolus over 1 minute, all of us are using it as 100 micrograms bolus over 1 minute. But then the studies have said that the actual ED90 of Carbotocin is much less. It is only in elective cases, it is only 14.8 micrograms, whereas in non-elective cases, it was found to be much more than 100 micrograms. That is, it was found to be 121 micrograms. When morbidly obese patients, surprisingly, the Carbotocin requirement was only 62.9 micrograms. So in short, the ED90 of Carbotocin varies from 20 to 100 micrograms. So what is the international consensus statement tell on the Carbotosin? Carbotosin, they said, for elective cesarean section, you have to give 100 micrograms over 30 seconds. Suppose the patient is a very low risk patient, smaller doses can be given. And if with the smaller doses, the uterus doesn't retract, then you can increase the dose up to, intermittently, you can increase the dose up to 100 micrograms, but it should not exceed 100 micrograms. Suppose the patient has come for intrapartum cesarean section, that is non-elective cesarean section, you have to give 100 micrograms over 30 seconds. If she doesn't respond, then you have to go for the second line of uterotonic drugs. So this is a Figo. Figo has come with some consensus on Carbotosin because everybody is using Carbotosin nowadays. So Figo has come with some consensus where we should not use Carbotosin. So the Figo has said that Carbotosin should not be used for labor induction or augmentation. It should not be used when the patient is not in labor. That is, patient is pregnant and she is not in labor. And in patients with cardiovascular diseases, liver or kidney diseases, because it gets metabolized and excreted by kidney, and in women with epilepsy, and in women with not sensitive to the Carbotosin, it should not be used. So now Carbotosin, whether it should be given bolus or an infusion. The WHO has recommended Carbotosin to be given as bolus. Even international consensus has recommended Carbotosin to be given as bolus. But there is a study which studied between a bolus and 100 micrograms diluted in 50 ml of normal saline over 5 minutes, and they have found that there are no significant differences. So you should, when you are giving it as bolus, make sure that you have to give it over 1 minute. Coming to cost effectiveness, actually, if you see the cost difference between Carbotosin and Oxytocin is hardly 20 rupees, 20 to 30 rupees, and Carbotosin is around, it is around 400 rupees, 300 to 400 rupees. So when this person, Cook et al., he has done a study on cost effectiveness and budget impact of Carbotosin in India, and he has found that when we use Carbotosin, we can in fact we can decrease the amount of the money that we spend on the women to prevent PPH. So maybe if the government gives Carbotosin, it may be good to prevent the PPH, and also it may come as cost effective. That is about the first line of uterotonic drugs. The second line of uterotonic drugs are, as we all know, it is Methogen or methyl ergometrine, Misoprostol, Carbocrust, and Suprostone. The WHO has taken this Suprostone also into the recommendation of the drugs, prostaglandin drugs, which can be used in pregnant patients to prevent PPH. Coming to Carbocrust, Carbocrust is a 15-methyl analog of naturally occurring prostaglandin F2 alpha. It stimulates myometrial contractions of the gravid uterus similar to labor contraction, and it also stimulates the GIT, bronchioles, and the arterioles. That is why it causes more amount of diarrhea and also bronchospasm. The dose is 250 micrograms IM every 50 minutes. So if up to 2 grams can be given. That is, up to 8 doses of Carbocrust can be given. And whether Carbocrust can be given as intramyometrial, there are no guidelines whether it can be given intramyometrial or all. So if it is given intramyometrial, the obstetrician has to be very careful that it doesn't go into the intravascular space. If it goes into the intravascular space, it can cause severe bronchospasm and pulmonary edema. The other prostaglandin is a Misoprost. Misoprost is very famous in third world countries because Misoprost can be given in any route. It can be given oral, it can be given rectal, it can be given the sublingual, or it can be given buccal. So when there is an emergency, it's better to give Misoprost as sublingual, because if you give sublingual, immediately the peak action occurs, and so the patient will have the uterotonic effect of the Misoprost immediately. Whereas if you give vaginal or rectal, it will have a sustained release. So it will act like an extended release tablet. So the dose is around 800 to 1000 micrograms, and this dosage of Misoprost also differs in different societies. And ACOG says 600 to 1000, whereas in different societies they say different kind. Mainly the thing with Misoprost is, the disadvantage with Misoprost is it causes shivering and it causes increase in temperature. Both shivering and increase in temperature increases the oxygen requirement by the pregnant patient. So suppose the patient is having PPH and the patient patient is bleeding and you are increasing the oxygen requirement in the, then there is a chance that this patient can deteriorate much faster. The other one is Misoprostol. Misoprostol is a drug which is being used in some of the European countries, especially in France. And actually, it was used almost 3 decades back. In there were in literature there were 3 or 4 deaths because of Misoprostol. So the other countries they are not using it. But then since in European countries it is being used, WHO has mentioned this also, and the WHO said severe cardiovascular or respiratory side effects have been uncommon. And since this is not available in India, I'm not going to discuss much about this drug. And coming to the other second line drug is the Methogen. Methogen, we used Methogen extensively, and Methogen was given IM or IV left and right. And even now in countries like UK, they give Methogen as a combination drug with Oxytocin. The main problem with Methogen is it cannot be given in hypertensive disorders of pregnancy and in condition heart disease complicating pregnancy. And the main problem is it causes coronary spasm and ischemia, and it can cause myocardial infarction and MI and death on the table. So now we know about the first line and the second line ultrasonic drugs, and whether to give a single ultrasonic or a combination therapy. And when WHO said that Carbotosin is the only drug which can be used as an effective single ultrasonic drug for the prevention of PPH. Otherwise, it's always better to go for a combined therapy if it is possible. So combined therapy for PPH prevention can be either with Methogen and Oxytocin, that is Synthometrin, which is being used in UK. And this has got a fixed combination, 5 units of Oxytocin and 500 micrograms of ergometrin. And usually they give it as an IM, or if they have to give it as an IV, it has to be given very slow IV. And the other combination can be with Carbocrust or it can be with Misoprost, and along with the combination of Oxytocin. Either it can be used as a prophylaxis or as a management. This combination therapies are more beneficial than Oxytocin therapy alone. And the third one, Carbotosin with Oxytocin. Carbotosin with Oxytocin, there are no studies on Carbotosin and with Oxytocin combinations. But then since both of them, they act on the same receptors, and if we have a fixed combination of Carbotosin and Oxytocin drug, or if we can manage the giving Carbotosin and Oxytocin in different ways, maybe we can have the immediate effect of Oxytocin and also the prolonged effect of Carbotosin, and we can avoid the prolonged infusions. Maybe the further studies has to say whether we can combine Carbotosin and Oxytocin or not. And tranexamic acid, though it is not a uterotonic agent, it is always, it has found its a definitive place in obstetric bleeds. Tranexamic acid is an inhibitor of plasminogen activation, and it prevents the conversion of plasminogen to plasmin and thereby inhibits fibrinolysis. It is usually given as a dose of 1 gram over 10 to 20 minutes, and its half-life is 2 hours. Main problem with tranexamic acid is that the antifibrinolytic effect, it persists up to 17 hours after administration. So you have to take care that this patient doesn't go into DVTs when you give tranexamic acid. And the women trial, the women trial has focused on tranexamic acid, and it has said that whenever the patient has PPH, that patient, this is tranexamic acid has to be given as a treatment for PPH, and the dose is 1 gram. As soon as you think that the patient has gone into PPH, 1 gram immediately, and then followed by 1 gram after 30 minutes if the patient still continues to bleed. And now the Women 2 trial has been going on, where they are seeing whether tranexamic acid can be given as a prophylaxis in vaginal deliveries to prevent the PPH. So to summarize, prevention of postpartum hemorrhage, for low-risk cesarean deliveries, Oxytocin 1 unit bolus over 1 minute, followed by a maintenance dose of 3 to 6 international units for 4 hours. And alternative can be Carbotosin 20 to 100 micrograms IV bolus over 1 minute. And in high-risk intrapartum cesarean deliveries, that is non-elective cesarean deliveries, oxytocin has to be given as 3 to 5 units bolus over 1 minute, followed by a maintenance dose of 8 to 16 international units for 2 to 4 hours. Alternate drug is again carbotocin 100 micrograms IV bolus over 1 minute. Suppose the patient has gone into uterine atonicity, then the first line still remains as oxytocin, and it can be repeated twice. Either you give it as a bolus or as 10 units, and then the second line can be either Methogen or Carbocrust or Misoprost, depending upon your hospital protocols. WHO said in 2019 that if you have a skilled personnel and if IV access is available and if heat stable carbotocin is available, carbotocin 100 micrograms is the first drug of choice. And if carbotocin is not available and if oxytocin is available and a skilled person is available to give oxytocin, you can give oxytocin 10 units either IM or IV. We usually prefer IM for cesarean, normal deliveries and IV for cesarean sections. If the oxytocin is also not available, and if Misoprost is available, you can have either Misoprost along with oxytocin, but Misoprostol cannot be given as a single agent, not recommended as a single agent, and ergometrin if it is not contraindicated, and fixed dose oxytocin and ergometrin if it is available. Suppose the skilled personnel or IV access is not available, WHO recommends Misoprost 400 to 600 micrograms per oral. This is the PPH protocol in our hospital. So all of you must have a PPH protocol which is good for your hospital. Whether you want to go for oxytocin bolus or whether you want to go for oxytocin as an infusion, whether you want to go for carbotocin or not, and what is the second line, whether it's Carbocrust or whether it is Methogen. So if you individualize your hospital protocols, it will be easy when you tackle a patient with PPH. Thank you.
Thank you very much, madam.
Sir.
Yeah, we have some questions. In fact, you have covered much of the basics and as well as the practical uses of the various uterotonics, as you said, and we have got few questions. Just now, we will take up the questions for this session first and finish it up.
Yes, sir.
Yes, sir.
Then we'll go to Dr. Manjula's presentation.
So, madam,
Yeah.
there's a question. Any role of vasopressors like noradrenaline as an uterotonic? Noradrenaline as an uterotonic?
No.
This
No.
is-
Noradrenaline cannot be used as a uterotonic. Noradrenaline, actually, we use vasopressors during anesthesia because when we are giving spinal, there is a vasodilatation. So to prevent the vasodilatation, we use noradrenaline. It is not to prevent as a uterotonic agent.
So next question is, can Methogen be used in a case of PPH in hypovolemic PIH patients now?
PAH patients are all usually hypovolemic, and Methogen is contraindicated in hypertensive patients. Methogen causes a vasospasm. So already in PAH patients, there will be a vasospasm because of the main pathology itself is vasospasm. So Methogen is contraindicated in PAH, and definitely it is contraindicated if the patient is hypovolemic and having PPH. Am I clear?
Yes, ma'am. Thank you, ma'am. Next question is, which is the better, Oxytocin or Methogen? Because most obstetricians request for Methogen while Oxytocin is being infused.
Yeah. Oxytocin is the first line of treatment. Many obstetricians, they are asking for Methogen, especially in the last 5-6 years, they are asking for Methogen because there is more focus on Methogen nowadays. The thing is, they say that Methogen causes more amount of contraction of the lower segment. Since we are doing a lower uterine segment cesarean section, if we give Methogen, the lower segment contracts well and the PPH and whatever, it decreases. So you can give Methogen also if the obstetrician feels that the patient is having, uterus is atonic and the patient is having PPH, there is no point in refusing Methogen. You can give Methogen, but I always advise you to give Methogen only IM. Don't give Methogen IV. If you give Methogen, we have seen deaths with Methogen IV. So anyway, you are having oxytocin as the first line of treatment. So your Methogen can be given. The only thing is you have to see that the patient doesn't have any contraindications to Methogen.
Okay, ma'am. Thank you. Ma'am, one more question is about the prophylactic use of oxytocin, which is being started just at the time of incision, that is before the extraction of the baby.
Yeah. Anesthesia practice depends upon the surgeon. So there are some surgeons who make an incision on the uterus and deliver the baby within 5 minutes. Those surgeons, they insist on putting the oxytocin before they give the skin incision. But there are certain surgeons who count the RBCs and they do cautery right from the time they are doing the skin. So if you add oxytocin before skin incision for such surgeons, it will take 10 or 15 minutes by the time the baby is delivered and the uterus retracts of the baby and it causes severe fetal bradycardias. So actually, by textbook, it is not advisable to add oxytocin drugs before the baby delivery. Even in the baby, the oxytocin goes in the similar concentrations as in mother, and it can cause jaundice and neonatal jaundice. So it is not advisable.
Madam, the other question is about probably we meant to say the combination, because I mentioned as recipe. So combination suggested for elective LSCS when the patient has mitral stenosis. So what combination of uterotonics is better?
Yeah. So in let us say heart disease, any heart disease. So we might be more bothered about mitral stenosis because it is a stenotic condition. So it's a fixed cardiac output condition. You cannot increase the cardiac output. So at the same time, you should not increase the heart rate in mitral stenosis. So when you give oxytocin to this patient, oxytocin can cause decrease in the systemic vascular resistance and it can cause tachycardia. So in cases of mitral stenosis, in such cases, you can start the oxytocin at the time of incision onto the uterus. So here you have to give oxytocin as an infusion 5 units per hour. So in 1 hour, you will be giving 5 units. So by the time the patient surgeon puts an incision on the uterus and the baby is delivered, at least 1 unit of oxytocin would have gone into the patient's body. So I find this 5 units per hour infusion of oxytocin by a syringe pump very useful and very safe in cases of heart diseases, especially in mitral stenosis.
Okay, ma'am.
And if you are asking about second line of oxytocic drugs, you can go for Misoprost. Misoprost is absolutely safe. Only thing is you need to give oxygen to the patient because it increases the temperature and also causes shivering.
Misoprost route, ma'am?
It can be given, it all depends upon how much the patient is bleeding. Suppose the patient is bleeding a lot, you have to give it, what we do is we crush and put it sublingual so that immediately the effect goes. Suppose the patient is not bleeding that much, you can put it rectal so that it will have a sustained effect. So even if the patient goes into the post-op, the patient will not have the secondary atonicity. And if the patient is not bleeding much, and the patient is not having any PPH or not that much, it can be inserted vaginally also. We don't insert it vaginally after delivery because anyway the patient will have some amount of lochia and the tablet may get washed up. So either sublingual or buccal or rectal.
The other question is, can Methogen be added to oxytocin infusion? Can both be infused in the same fluid?
Yeah, when you do polypharmacy, if something happens, we will never know what went wrong. So I have seen deaths with Methogen. So even if it goes very slow also, I don't prefer giving Methogen IV. But yes, it can be given.
And any studies which are regarding the myometrial injection of Methogen or Carbocrust, which are ongoing or done?
Actually, intramyometrial has not been approved, so there are no studies on that. But then if the obstetrician, even in literature, they say that if the obstetrician feels it has to be given intramyometrial, it can be given provided the obstetrician takes care that it doesn't go intravascularly. So see, in the uterus, the blood vessels are in sinusoids. They are not in capillaries. So even if you find a negative aspiration, it may still go into some sinusoid and it can go into the intravascular space. So there's always a danger that the patient can land up in pulmonary edema or severe bronchospasm. So you should also be geared up, and even the obstetrician also should take the responsibility.
And this is regarding Carbotosin, madam. It's contraindicated in seizure disorder, but does it mean it's contraindicated in severe PE as well?
Actually, Carbotosin shares all the contraindications of Oxytocin. It is contraindicated. It is not contraindicated in PAH. It is contraindicated in seizure disorders because it causes water intoxication and it can precipitate cerebral edema. So if the epilepsy is totally controlled, we may give Carbotosin, but Figo has said against it. So it can be given in PAH patients.
Ma'am, one more is side effects of Oxytocin you are mentioned as PPH. How is that possible?
Yeah, that is because Oxytocin can, if the patient is on Oxytocin induction or Oxytocin augmentation of labor, only in such conditions, Oxytocin can cause PPH, because in such conditions, the Oxytocin receptors undergo desensitization. So even if you give Oxytocin to the patient, that's what happened in our first case. They have given Oxytocin to the patient, but the Oxytocin receptors are desensitized to the Oxytocin. They are not responding. So it causes more amount of PPH. So the PPH is because the Oxytocin caused desensitization. Because of the desensitization, there is non-progression of labor. Because of the non-progression of labor, there's a prolonged action of Oxytocin, and then the patient has been taken up for cesarean section. Again, the Oxytocin receptors are not responding. So in such conditions, better to give only a basic dose of Oxytocin and then immediately go for a second prophylactic dose, not a treatment dose, prophylactic dose.
Okay. Ma'am, some obstetricians keep Misoprostol tablets into the uterine cavity. Is it useful?
It is not described, but something like submucosal and buccal, rectal. So they think it gets absorbed from any surface of the body. Maybe it gets absorbed. We don't know. Many obstetricians, they put one tablet of Misoprost in the uterus. Since it is not nothing dangerous, it may not be useful.
Okay, ma'am. Thank you, ma'am. And any more questions?
Yeah, Dr. Kousalya.
Sir.
Now that we have a lot of practitioners attending along with the postgraduates today,
Sir.
I think that one main take home is the doses which you have discussed so far. It's more advisable to customize for each of the patient.
Sir.
And each of the obstetrician also, as you are suggesting, in terms of timing, in terms of the dose, and in terms of dose means both the bolus and the infusions for the patient. And with respect to some discussion about Methogen. So, for example, I would say for more than last 20 years, I have not used Methogen.
Sir.
And I never advise my postgraduates and colleagues not to use Methogen. And not using Methogen has never caused any morbidity and mortality in the practice.
Yes, sir.
So at least since Carbocrust also has come into routine use, Carbotosin has come recently. So we were regularly using Carbocrust before that. Even though some you have suggested that Europe and the UK, they have started using Methogen more frequently nowadays. Both theoretically speaking and practically, what I have seen is it is really a dangerous drug to administer.
It is dangerous, sir. I have seen deaths with Methogen.
Yeah, so very dangerous. And the sustained vasospasm throughout the body. First of all, at the simplest level is the patient getting severe headache. And secondly, at the other extremes, precipitating coronary vasospasm and even ischemic episodes. I think we should not be using it despite some advices. And it should be really a last resort. So, what do you think in terms of have you used Methogen in the recent past?
No, sir. I am a person to use Carbocrust. But then if you attend the OBG conferences, they are insisting on giving Methogen.
And if it
So
is
that
part
is
of,
why many obstetricians, they are asking us to give Methogen nowadays.
so, but okay, we have some obstetrician friends also attending today's program,
Sir.
and they are also seeing in the YouTube.
Yes,
But
sir.
as I say, at least many of us who are working in both private and in the teaching hospitals, attending to so many cesarean sections of different categories, definitely we are not happy when we use Methogen.
Methogen. The
Yeah.
thing is, sir, Methogen also increases the blood pressure. So even if the patient is bleeding, we have a spurious feeling that the patient's blood pressure is okay. And in the decade or 20 years back, they used to give Methogen and also sedate the patient with Fortwin, which I find a very, very dangerous combination. Thank God nowadays Fortwin is not available. So, and many people, they used to give Methogen IV, which is a practice which I don't like at all. And but if there is no contraindication and if the obstetrician feels that Methogen has to be given, then it can be given IM. That is the only thing I can't say that it is absolutely contraindicated and we should not use Methogen.
Right. No, that second part, I definitely agree in the sense an IM dose of Methogen can be given for the patient. At least we don't have an acute change in the intravascular status of the patient. That's the first one I want to convey. Second thing is with respect to the vehicle for Oxytocin. I think not much of a stress is provided during practice with respect to the vehicle.
Yes, sir.
Is it no? Basically, we are happy with an electrolyte solution, especially ringer lactate. But still, there is a practice of administering with dextrosaline. Dextrose per se, definitely, all of us know we don't want it to be administered with dextrose during spinal anesthesia with Oxytocin. And is it okay to administer with the dextrose normal saline?
No, sir. DNS, okay, sir. DNS, that too, intraoperatively. Usually, sir, we don't advise Oxytocin to be given in dextrose-containing solutions for augmentation or for induction of labor because it causes maternal hyperglycemia and it can cause fetal hyperglycemia, which is not good. And secondly, intraoperatively also, we don't advise DNS because surgery itself is a stress and it can cause increase in the glucose levels in the body. And we need not give another glucose containing solution to the patient. So intraoperatively also, we don't advise DNS to the patient. So either you can go for only RLs intraoperatively or you can go for electrolyte solutions, balanced salt solution intraoperatively and keep DNS as a maintenance solution in the post-op. So for all practical purposes, you can always add Oxytocin in RL or NS. You can avoid DNS.
Yeah, just to convey to the postgraduates, it's mainly because in addition, so the 5% dextrose is more likely to, once it is administered, it becomes
5% dextrose is it? No, sir. There is no role of 5% dextrose at all.
Yeah. So our, in fact, I mean, PG should understand it should never be administered in 5% dextrose.
Yes, sir.
For all important reasons. Also because Oxytocin has got tendency to promote some retention of water, even though it is unusual. ADH-like action, especially when we administer at greater rates of infusion. And we are left with pure water in the circulation as dextrose enters into the cellular compartment. So this is another thing. And so what would be a routine practice per se, in the sense you advise us, means overall for the current group, in an elective case where the patient is not in labor, would you advise a bolus of 1 or 2 or 3 units? And what would be infusion?
Sir, personally, I advise to follow WHO guidelines.
Okay.
Because it applies for everyone. It applies for postgraduate. It applies for any person who is working in a periphery. It applies for everyone. So if you follow WHO guidelines, for normal deliveries, go for IM Oxytocin 10 units. And for cesarean sections, go for IV Oxytocin as an infusion. So even if you go for a rule of 3, you are giving 3 units, waiting for 3 minutes, giving 3 units, waiting for 3 minutes, and giving another 3 units. So in 10 minutes, you are giving 10 units. So why don't you give it as a 10 units infusion in 100 ml of NS or the last 100 ml of whatever fluid you are giving to the patient? I find that very useful, sir.
Yeah. So that's the way, because we have to set a protocol. In fact, you have a nice protocol. It was displayed at the end. So you may please give a better copy by
Yes, sir.
WhatsApp or
I'll
email.
share with you, sir.
So I will give it to the participants in today's program, because that's the
Yes,
one which
sir.
is going to help their practice also,
Yes, sir.
basically. And the Carbotosin thing was a very good discussion.
Sir.
But is it okay if we practice at 20 microgram intermittent doses rather than 100?
Sir, that 20 microgram is they have a lab, sir, in Toronto. They have a lab. In that lab, they have found that even 20 micrograms is enough. 14.3 micrograms is enough. But then it was not studied clinically.
Okay.
So according to WHO, it is 100 micrograms even now. So what WHO says is if it is a very low risk patient and if you want to give only 20 micrograms, you can give 20 micrograms, wait for 2 minutes, and if the patient is still not having a uterine tonicity, give another 20 micrograms. Like that, you can go up to 100 micrograms. So I am using Carbotosin, sir, and I find Carbotosin very useful.
Okay. Yeah. Now it's almost become more common nowadays.
Yes,
Our
sir.
obstetric colleagues are also become more confident, and
Yes,
despite
sir.
the cost factor,
Yes, sir.
they are happy with the extent of the uterotonic effect, and the risk of PPH is they feel it is reduced basically.
Yes, sir. Only thing is we should give it over 1 minute. By 1 minute, because it causes tachycardia.
Yeah. 30 seconds to 1 minute, just 1 minute.
1 minute, sir. You can dilute in 10 ml syringe and give it over 1 minute, or you can have a 3-way cannula and slowly give it over 1 minute.
1 minute. Okay.
Yes, sir.
Right.
Regarding Carbotosin, so there's one more question, like if oxytocin fails because of receptor desensitization, does that mean that Carbotosin will also fail?
Theoretically, it means the same because both they act on the same receptors. So that is why I have put in the last slide that if we have a combination of Carbotosin with oxytocin, maybe theoretically like combining xylocaine and bupivacaine. Initially, we used to combine like that for blocks. Nowadays, we are not doing that because the concept has changed. But then that's what I feel, that if we have a combination of Carbotosin with oxytocin, maybe we can have the immediate effect of oxytocin and the prolonged effect of Carbotosin also. But if there is a situation that oxytocin fails, even Carbotosin can fail. So in such a situation, even if you give Carbotosin, you should have an idea that this Carbotosin may fail and you should be ready to use a second line uterotonic agent.
Yeah, after all, there are limited number of oxytocic receptors.
Yeah.
So
both they act on the same receptors, sir.
Yeah. So probably initially, as you say, for an early action, we can use oxytocin, follow it up with a single dose of Carbotosin.
Maybe, sir. Actually, studies are not there, but
not yet.
I am thinking like that.
Yeah. That's it. Yes, some more questions are there?
So one last question, can Carbotosin be added to last 100 ml of oil instead of bolus rather than giving it bolus?
Actually, that is what in one of my slides I told, that they have done why we give a infusion not by bolus, because we are scared about the hemodynamic side effects. So they have done a study where they have seen a bolus as well as a infusion, and since there are no hemodynamic changes in both the ways, we can as well go for a bolus. Yes, you can add it in instead of 100 ml, you can add it in the last 20 ml if you are that scared of giving Carbotosin, but it can be given over 1 minute also as a bolus.
Dr. Subramaniam, you want to ask anything further? You put up that question.
Nothing, sir. Very good topic, sir. Really very lively interactions and well presented, sir. Actually, you select very good topics, especially for postgraduates and practicing anesthesiologists. I have been using Carbotosin since recent times, sir. I found it very useful.
Okay.
Carbotosin. But my question is, if the uterus doesn't retract with 100 mics of Carbotosin, so as Madam said, we should not repeat the Carbotosin. So we have to go with the second line of drugs. like Methogen or prostaglandin. But much has been discussed about Methogen, sir. But even prostaglandins also have some side effects, sir, to the body. So that has to be also kept in mind.
Yeah, I thought if I discuss everything, it may become too prolonged and.
No, in fact, I think in one of these studies where Methogen and Carbocrust have been compared. I think it's a huge series of more than 1,000 patients. They found that, in fact, Methogen could be a better agent in terms of the hemodynamic effects. I can share with you later. They studied the uterine anatomy, an instance of blood transfusion, the uterine artery or epigastric artery ligation, and even hysterectomy. So they found that Methogen was better than Carbocrust. By a study, authored by Butwick, I think, Dr. Kousalya.
I am not aware, sir.
Yeah, Butwick et al. It was a series of more than 1,000 patients where they compared methyl ergonovin with Carbocrust. So that's Dr. Prashant has raised his hand. Dr. Prashant, please.
Sir, good evening, sir. This is Dr. Vandana. Sir, I wanted to ask Madam, Carbotosin has been shown in studies to have some diuretic action. So is there any difference when it comes to preloading, when we are preloading patients where we are using Oxytocin and preloading before use of Carbotosin? Is there any difference?
Actually, we don't preload nowadays. So there should not be any difference. Only thing is since oxytocin has got antidiuretic effect, if at all the urine output is less, we tend to give a diuretic like Lasix. So if there is, as you said, Carbotosin can cause little amount of diuretic effect and there will be more amount of urine output. Only thing is we have to see is input-output chart and ask the patient to have. We give fluids very easily to the patient. Within 6 hours, we give fluids to the patient. So ask them to have oral fluids. That's all, nothing else. It doesn't cause that much of a diuretic effect. It does cause it doesn't cause antidiuretic effect. And so it reflects as a diuresis.
Madam, now the trend is co-loading rather than preloading now, madam.
Yes, sir. Yeah. Co-hydration.
Do you practice co-loading now?
Yes, sir. We have been practicing co-hydration from a long time.
Okay, very
We
good.
don't preload at all.
Yeah, that's true. Thank you.
Thank you,
madam. Very wonderful topic and nice discussion. Lot of question means the topic is very good. And your presentation is also very good, madam. Thank you, sir. Balabhaskar, sir.
Thank you.
Thank you, sir, for giving me this opportunity.
Yeah, there has been quite an amount of discussion. We have another excellent topic by Dr. Manjula. Next, Dr. Josna.
Yes, sir. Thank you, ma'am, Kousalya, ma'am, for patiently answering all the queries. Our next topic is CPR in pregnancy, that is cardiopulmonary resuscitation in pregnancy. We have Dr. Manjula Sudhakar Rao with us. I request Dr. Srinivaslu to introduce our speaker.
Good evening, all. It's my pleasure to introduce Dr. Manjula Sudhakar Rao. She is assistant professor working at Department of Anaesthesiology, Anaesthesia Medical College, Manjula. She is very academically active. She was organizing secretary for the comprehensive exam-oriented tutorials of 2023. She was faculty at PGXL 2022, and she has conducted various quiz programs, given guest lectures, and has been a part of various academic events. And she is the CBME coordinator for the Department of Anaesthesiology at Anaesthesia Medical College. She has published articles in various anesthesia journals, and her field of interest are regional, obstetric, and high-risk anesthesia and critical care. Over to you, Dr.
Thank you, Subramaniam sir, for the wonderful introduction. Before going on to my presentation, I would like to thank Dr. Balabhaskar sir and Dr. Josna Madam for giving me this opportunity to speak in this platform. Topic for my today's talk is cardiopulmonary resuscitation in pregnancy. It's a very important topic and less known. So, resuscitating a pregnant woman is similar to standard adult resuscitation in several aspects, but you should always remember the considerations are uniquely different from that of an adult patient, because here we are dealing with two lives, the mother and the fetus. So we need to know these two definitions. They are maternal mortality, that is defined as the death of a woman during pregnancy and up to 42 days after the delivery or termination of pregnancy, provided that the cause of death is related to or aggravated by the pregnancy or its management. Second is the maternal near miss. It is defined as a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. So coming to a little bit of statistics, so US nationwide inpatient sample suggested that the cardiac arrest occurs in around 12,000 admissions for delivery. So globally, 800 maternal deaths occur daily. And according to the last census, maternal mortality rate in India is 97 per 1 lakh live births. I did not get much about the maternal near miss data. One data that I got from the Netherlands, that was showed an incidence of maternal near miss of 1 in 141 delivery wards. So why is it important to know about the CPR in pregnancy? Because the knowledge deficits and the poor resuscitation skills could be the major contributors to poor outcomes once the cardiac arrest has occurred. And the recent data showed that the rate of survival to the hospital discharge after maternal cardiac arrest is as high as 58.9%. It's far higher than most of the arrest populations. So justifying appropriate training and preparation for such events becomes crucial. So I will be talking about the recommendations. Here the recommendation says that the core team members with responsibility for pregnant women should be familiar with the physiological changes of pregnancy that affect resuscitation technique and potential complications. So that comes in class 1 and level of evidence. So I will be dealing with all this strength of recommendation and quality of evidence. Majority of you all know, just for the postgraduates to know a little bit about it. The class 1 is a strong strength of recommendation where the benefit is more than risk. That means you highly recommend, it is beneficial and effective. Class 2A is a moderate benefit over risk. So it is reasonable and can be useful or effective. So class 2B is a weak association. So you might suggest or might be reasonable, benefit is still more than the risk. The class 3, it is a moderate where there is not much of a benefit over risk, or it could be a strong, like it is a risk is more than the benefit, it could be harmful. And what about the quality of evidence? The level A evidence is through a high quality evidence from more than one RCTs. And level B is a moderate quality randomized RCT, or it could be a moderate quality one or more non-randomized RCT. The level C is a limited data, or it could be consensus from the expert opinion. A recommendation of a level of evidence does not imply that the recommendation is weak. Many important clinical questions are addressed in guidelines, do not lend themselves to clinical trials. So here, although RCTs are unavailable, there may be a very clear clinical consensus that a particular test or therapy is useful or effective. So, as I said, all these core team members should know about the physiological changes in pregnancy. So little bit, I will brush upon the physiological changes in pregnancy just for the postgraduate information. So cardiac output in pregnancy, it increases up to 30 to 50%. So mainly the stroke volume, and to a lesser extent, the maternal heart rate, it increases from 15 to 20 beats per minute. As you all know, the plasma volume starts increasing by 6 weeks. It increases up to 50% by 34 weeks. The systemic vascular resistance decreases. It's mainly because of the endogenous vasodilators, progesterone, estrogen, and nitric oxide. As a result, that decreases the mean arterial pressure. So what happens because of the gravid uterus? Gravid uterus, what it does is it increases the afterload through compression of the aorta and decreases the preload by compressing the IVC, inferior vena cava. It starts from 12 to 14 weeks of gestational age. As a result, supine hypotension, which is the most favorable for resuscitation, can lead to hypotension. So there is an MRI study which says that what are the benefits of the left lateral position in a pregnant woman. The study said that at 20 weeks and 32 weeks of gestational age, there was a significant increase in ejection fraction of 8% at 20 weeks to 11% at around 32 weeks. And the stroke volume increased from 27 to 35% in left lateral position. At 32 to 34 weeks, there is an increase in end diastolic volume of 21%, and there is an increase of cardiac output of 24%. The uterine placental blood flow can increase from 50 ml per minute to 1000 ml during pregnancy, receiving a maximum of 20% of the maternal cardiac output at term. The uterine vascular reactivity is altered, characterized by reduced tone, enhanced vasodilatation, and blunted vasoconstriction. Hence, if there is a systemic hypotension, it can overwhelm this compensatory mechanism, which makes an attempt to maintain the uterine blood flow. Coming on to the respiratory physiology, the functional residual capacity decreases by 10 to 25%. As you all know, the gravid uterus pressing on the diaphragm. Then there is an increased ventilation. There is an increase in the tidal volume and mainly the minute ventilation in the first trimester. It can reach from 20 to 40% above the baseline by term. There is a mild respiratory alkalosis with compensatory renal excretion of bicarbonate. If you take an ABG, you see that in majority of the pregnant women will have a PaCO2 of 28 to 32 millimeters of mercury and a plasma bicarb of 18 to 21 milliequivalents per liter. What about the oxygen consumption? Oxygen consumption increases drastically, meeting the demands of the fetus and maternal metabolic processes, reaching a level of 20% to 33% above the baseline by third trimester. Hence, there is the reduced functional residual capacity reservoir and increased consumption of oxygen are responsible for rapid development of hypoxemia in response to hypoventilation or apnea in pregnant women. And what happens to the ODC curve? That is shifted to the right in mother during pregnancy. The P50 increases from 27 to 30 millimeters of mercury. What it means? That means that a higher pressure of oxygen is therefore required to achieve the same maternal oxygen saturation. But luckily, a little bit, if you take the fetus side, the ODC shifted to the left. The P50 here is 19 mm of mercury, conferring relative resilience to hypoxic condition compared to the mother. The upper airway edema and the friability occur as a result of hormonal effects and may reduce visualization during laryngoscopy. And there are high chances at the increased risk of bleeding. What happens to the renal physiology? There is glomerular hyperfiltration and the increase in renal blood flow by 40%, because of which the fetal detoxification of metabolic byproducts and maintenance of maternal osmoregulation occurs even in the face of increased circulatory intravascular volume. There is altered tubular function, hence it prevents wasting of glucose, amino acids, and proteins that is required for both maternal and fetal metabolism. What happens to the oncotic pressure? The oncotic pressure reduces. So hence there is increased tendency of pulmonary edema in the pregnant patient. So you should be very careful about it. What about the gastrointestinal physiology? The progesterone relaxes the gastroesophageal sphincters and prolongs the transit time throughout the intestinal tract during the second and third trimester. So because of this, there are high chances of aspiration in these patients. So coming after the physiological changes, we should know who are these critically ill pregnant patients. So here today I'll be talking mainly CPR in hospital pregnant patients. So who are critically ill patients? The sepsis patients, the patients, the trauma patients which are life-threatening, or if the patient is having any life-threatening cardiac conditions, or where you are a patient who is eclamptic and which is not controlled, the blood pressure is not controlled by various antihypertensives. These patients require a highly critical care unit and a critical care team, or a intensive care unit with the vigilant monitoring. In these patients, pre-event planning is extremely essential. So what do you mean by a pre-event planning? The team on these units need to prepare for unexpected emergencies in these patients by covering the following 4 important steps. So first is prepare for the cardiac arrest. So you should educate the staff about the management of the cardiac arrest in pregnancy. So preparation for perimortem cesarean delivery, which is most important. Identify the contact details or appropriate code calls to mobilize the entire maternal cardiac arrest response team. And the availability of equipment for cesarean delivery and resuscitation of the neonate becomes extremely essential. And this is the pre-cardiac arrest, perimortem cesarean delivery consent must be taken. Third is the preparation for management of obstetric complication. The stock drugs equipment that is commonly available in obstetric units, including the oxytocin and prostaglandins, should be available. So the pre-event planning for the power of attorney related to the healthcare decision should be done for all the critical ill patient. And decisions involving the resuscitation status of the neonate. The fetal viability should be made in collaboration with the obstetrician, neonatologist, and family. The decision depends on the gestational age and to a significant degree, the neonatal facilities that are available in the hospital. This information should be clearly documented. And the British Centre for Maternal and Child Enquiries report in 2011 stated that the timely recognition of potentially life-threatening condition play an important role in appropriate institution of treatment. In a more recent publication using a large British ICU data set, Carl et al. Described the evaluation of pre-existing obstetric early warning scores with the development and validation of a new obstetric scores and demonstrated that there is an excellent discrimination between the survivors and non-survivors if we are using this new score. So what are the parameters in this new score? There are 6 parameters. One is systolic BP, respiratory rate, heart rate, FiO2 to keep a SATs more than 96%, temperature, and the consciousness. So the scores are given from 0 to 3. A score greater than or equal to 6 should trigger a call for support from the intensive care unit or the rapid response team and initiation of continuous monitoring of vital signs. So what are the recommendations? The pregnant women who become ill should be risk stratified by the use of validated early obstetric warning score. Then the hospital units with the pregnant women in their care should ensure that the proper pre-event planning has been instituted, including preparation for maternal cardiac arrest and neonatal resuscitation. That is class 1 and level of evidence is C. So how do you manage an unstable pregnant patient? The rapid response to instability in the pregnant patient is essential for the prevention of cardiac arrest. The IV access must be established. Maternal hemodynamics must be optimized. Hypoxemia must be treated. The recommendation is the patient should be placed in a full left lateral decubitus position to relieve the iotocaval compression. The administration of 100% oxygen by face mask to treat or prevent hypoxemia is recommended. That is class 1 recommendation with the level of evidence C. And the intravenous access should be established above the diaphragm to ensure that the intravenously administered drug is not obstructed by the gravid uterus, and the precipitating factors should be investigated and treated. So coming to the cardiac arrest management, the basic life support. The cardiac arrest in pregnancy in hospital BLS algorithm should be used as a guide to management. So as we all know, this is the same as an adult. So a patient becoming unresponsive, there is no breathing or no normal breathing. The uterus is at or above the umbilicus. You need to activate emergency response system. Here the BLS response starts and a minimum of 3 additional staff is required and the crash cart should be brought. So, and then there is a ACLS team and the maternal code team activation is done. And the second responder gets an AED immediately and starts applying. Then there is a pulse check. The definitive pulse check should be done not less than 5 seconds up to 10 seconds. If there is a definite pulse, so use a bag mask, give 1 breath every 5 to 6 seconds, recheck pulse every 2 minutes. You should document time and start high quality chest compression. So apply an AED as early as possible when you get an AED. If the rhythm is shockable, it gives give one shock and resume CPR immediately for 2 minutes. If it is not shockable, resume CPR immediately for 2 minutes, check rhythm every 2 minutes if not shockable. And if there is a PEA, fluid resuscitation to be done. And perform appropriate airway management. And the most important in this is perform continuous manual left uterine displacement. I'll be talking about each thing. So mainly the chest compressions I'll be dealing with in detail. About the BLS airway management, appropriate airway management for pregnancy, you should open the airway by using a head tilt chin lift maneuver. If not a trauma patient, consider the cervical spine injury. Administer 100% oxygen at greater than 15 liters per minute. When available, perform bag mask ventilation. Seal mask, ensure no leak around the mask. By two-handed technique is preferred. Deliver each rescue breath over 1 second. Give 2 breaths for every 30 compressions. Give a sufficient tidal volume to see a visible chest rise or fog within the mask. If not, reopen the airway and improve the seal. Consider using the oral airway. Avoid excessive ventilation. Then who are the first responders? The first responders who witnessed the arrest. The basic emergency care is extremely crucial. The rapid mobilization of the expert resuscitation team. So the BLS performed competently until the arrival of this team gives the woman the best chance for return of spontaneous circulation. So accomplishing a well-coordinated and executed first response is challenging as these patients are vulnerable to hypoxemia and hemodynamic disadvantage. These patients have a rapid development of desaturation with apnea and iotocoval compression when the patient is unconscious and supine. The first responder should initiate the usual resuscitation measures simultaneously. This is important. The placement of a backboard and provision of effective chest compression and appropriate airway management, early defibrillation in case of shockable rhythm, and a continuous manual left uterine displacement. To accomplish all these tasks effectively, a minimum of 4 BLS responders should be present. To get the backboard, it's essential to get the backboard, but the initiation of CPR should not be delayed because of this backboard. The chest compression in pregnancy. The high quality chest compression are essential to maximize the patient's chance of survival. The correct rate and depth of compression must be performed and interruptions must be minimized. The hospital beds that we normally use in ICUs are not typically firm. Some of the force intended to compress the chest results in mattress displacement rather than chest compression. The use of backboard is recommended. The air-filled mattresses, if the patient is lying on, should be deflated when CPR is performed. The chest compression physiology has been studied only with the patient in supine position and has not been studied in a patient which is tilted. The chest compression recommended for the pregnant patient are same as most current recommendation for adult resuscitation. So what are the recommendations for chest compression? It should be at a rate of 100 to 120 per minute at a depth of at least 2 inches, that's 5 centimeters, allowing full recoil before the next compression with minimal interruption. Compression ventilation ratio should be 30:2. So here there's a class 2A level of evidence is C. The interruption should be minimized and should be limited to less than 10 seconds except for the specific interventions such as insertion of an advanced airway or the use of a defibrillator. The patient should be supine with as I said, the left uterine displacement for a chest compression. There is no literature examining the use of mechanical chest compression in pregnancy, and this is not advised at this time. And a little bit on manual left uterine displacement, when you compare it with the 15-degree left lateral tilt has shown that there is a less hypotension and a significantly lower ephedrine requirement during a cesarean delivery. So there is an easier access for both airway management of defibrillation as the patient is in supine. Patient can remain supine and receive usual resuscitative measures, including high quality chest compression without any hindrance. It can be performed from the left side of the patient or right side of the patient, and the uterus is cupped or pushed upwards or leftwards of the maternal vessels. So here, the left side is showing a one-handed technique from the right of the patient during adult resuscitation. Here, that is a two-handed technique from the left side of the patient, displacing the uterus on the left side and above. Now, what are the recommendations? The continuous manual left uterine displacement should be performed on all pregnant women who are in cardiac arrest in which uterus is palpated at or above the umbilicus to relieve iotocaval compression during resuscitation. If the uterus is difficult to access, example in morbidly obese patients, attempts should be made to perform the manual LUD if technically feasible. So what should be the position of the hands during chest compressions as you feel that where to compress when there is a gravid uterus? So there is no scientific evidence to support the changing the recommendation for hand placement for chest compression in the pregnant patient compared with that of a non-pregnant patient. Previous guideline recommended that the placing the hand was slightly higher on the sternum in the pregnant patient, but no scientific data is there to support this recommendation. So recommendation says that the rescuer should place the heel of one hand in the center, that is middle of the victim's chest at the lower half of the sternum, and the heel of the other hand on the top of the first, so that the hands overlap and are parallel. That is a class 2A, and again level of evidence is C. So should we transport this pregnant woman from the arrest stage to a to OT? This is a question. So what they say is that simulation of the chest compressions on mannequins has shown that the quality of CPR decreases during transport to the operating room. So the recommendation says that because an immediate cesarean delivery may be the best way to optimize the condition of the mother and the fetus, the operation should be optimally occur at the site of arrest. The pregnant patient with in-hospital cardiac arrest should not be transported for cesarean delivery. But the management should occur at the site of arrest. That has a class 1 level of evidence. Transport to a facility that can perform a cesarean delivery may be required when indicated where there is a out of hospital cardiac arrest or the cardiac arrest that has got no facility for cesarean section. So what about the defibrillation issues during pregnancy? Is it different from a non-pregnant? There is a prompt application of defibrillation in the setting of ventricular fibrillation or pulseless VT is critical to maximize the likelihood of survival. This is no different in pregnant patient, as the transthoracic impedance remains unchanged during pregnancy. Hence, the energy required for the defibrillation during cardiac arrest in pregnancy would be the same as most current recommendation for the non-pregnant patient. So where do you apply? Application of the defibrillation and the cardioversion shock to the maternal chest would be expected to pass minimal energy to the fetus and is considered safe in all stages of pregnancy. Defibrillation would be unlikely to cause electrical arcing to fetal monitors, and the presence of fetal monitors should not deter providers for the use of rapid defibrillation. So when indicated, defibrillation should be performed in the pregnant patient without any hesitation or delay. The recommendation is the same current recommended defibrillation protocol should be used in all pregnant as in a non-pregnant patient. There is no modification of the recommended application of electric shock during pregnancy. The patient should be defibrillated with biphasic shock energy of 120 to 200 joules with subsequent escalation of energy output if the first shock is not effective, and the device allows this option, and a monophasic of 360 joules. The compression should be resumed immediately post-delivery of the electric shock. For in-hospital settings where the staff has no ECG rhythm recognition skills or where defibrillators are used infrequently, such as in obstetric unit, the use of an automated external defibrillator may be considered. That is a class 2B level of evidence C. And the defibrillator pad placement, anterolateral pad placement is recommended as a reasonable default. The lateral pad or the paddle should be placed under the breast tissue, an important consideration in the pregnant patient. The use of adhesive shock electrodes is recommended to allow consistent electrode placement. Coming on to the ACLS algorithm. Now the BLS team's actions are ongoing as they are giving high quality chest compressions and defibrillating whenever indicated and the monitoring the CPR quality. Now the maternal cardiac arrest team arrives, and what do? They should consider the etiology of the cardiac arrest. They should rule out all the etiologies. It could be anesthetic complication, accidents, bleeding, cardiovascular. It could be toxicity because of the drugs, embolic events, could be fever, and like in adult to rule out the 5H and 5Ts, and hypertensive disorders that has gone complicated. And what about the maternal intervention? The maternal intervention, you should have an appropriate airway management. As this patient, you have to anticipate the difficult airway, and the most experienced providers are preferred. The IV access to be placed above the diaphragm, give typical ACLS drugs and dosages, and if assess for hypovolemia and give fluid boluses and blood blood and blood products when it is required. If the patient is receiving IV magnesium, if the patient is having preeclampsia or a pre-arrest, stop magnesium and give intravenous or intraosseous calcium chloride 10 ml of 10% solution or calcium gluconate 30 ml in 10% solution. What about the obstetric intervention? For patient whose uterus is at or above the umbilicus, you should continuously give manual left uterine displacement, remove and detach fetal monitors, prepare for emergency cesarean delivery. What about the neonatal team? To prepare, should be prepared to receive the infant. If no ROS is attained by 4 minutes of resuscitative efforts, consider performing immediate cesarean delivery. I'll be talking about the airway management in this ACLS protocol. The recommendation, there should be one call to action that activates the maternal cardiac arrest team, notifies all members, and ensures that a specialized equipment is brought to the scene without delay. A maternal cardiac arrest team would be ideally composed of the adult resuscitation team, could be from critical care, from emergency physicians, nurses, internal medicine physicians, or from services from the general surgery, you name any, all other. So it should be based on the institution policy. And mainly the obstetrician nurse, anesthesia care providers who are an obstetric anesthesiologist or a certified anesthesiologist or a certified nurse anesthetist. The neonatal team has a neonatal nurse, physician, neonatal respiratory therapist or equivalent. In centers without any obstetric or neonatology services, it is suggested that the cardiac arrest committee and the hospital emergency services discuss the contingency plan in the event of maternal cardiac arrest. So this is most important. The leadership, who takes the leadership? Even if the team members are if they are very good at giving, if there is no coordination, if there is no leadership, then the whole thing will become a flop. So what we have to do is to take a leadership during this arrest protocol. The leadership during a maternal arrest is complicated given the multiple teams involved. The leadership will depend on where the arrest occurs and may be specific to the institutional practices. In general, there should be a team leader each for adult resuscitation, obstetric care, and neonatal or a fetal care. For an effective approach, all team leaders must communicate effectively together to make decisions about the code management. And coming on to the most important for the anesthetist is the airway management. What about the recommendations for airway management? Endotracheal intubation should be performed by an experienced laryngoscopist. That could be a class 1 level of evidence C. Starting with an ET tube with a 6 to 7 millimeter inner diameter is recommended. Optimally, no more than 2 laryngoscopy attempts should be made. A supraglottic airway placement is preferred rescue strategy for the failed intubation. That comes under class 1 level evidence C. If attempts at airway control fail and mask ventilation is not possible, the current guidelines for emergency invasive airway access should be followed. And always remember, call for help and obtain equipment. If there is the prolonged intubation attempt should be avoided to prevent deoxygenation, prolonged interruption in chest compression, airway trauma, and bleeding. The cricoid pressure is not routinely recommended. That is the class 3. It could be harmful. Level of evidence C. The continuous waveform capnography in addition to the clinical assessment is recommended and the most reliable method for confirming and monitoring correct placement of endotracheal tube. To monitor the CPR quality, there is a PET levels of 10 millimeters is considered as the adequate chest compression, and to detect ROS. So the finding consistent with the adequate chest compression or ROS include, if ROS is attained, there is an abrupt sustained rise of end-tidal CO2 tension levels more than 40 millimeters of mercury. The interruptions in the chest compression should be minimized during advanced airway placement. So what about the arrhythmia-specific therapy during the cardiac arrest? For refractory or a shock-resistant ventricular fibrillation and tachycardia, amiodarone 300 milligram bolus with 150 milligram doses repeated as needed. In the settings of cardiac arrest, no medication should be withheld because of the concerns about the fetal teratogenicity. The physiological changes in pregnancy may affect the pharmacology of medication, but there is no scientific evidence to guide a change in current recommendation. Therefore, the usual drugs and doses that are recommended during ACLS to be given. So other drugs, what are the other drugs used during ACLS? The vasopressors, the epinephrine and the vasopressin have been used with the goal of increasing myocardial and cerebral blood flow and improving patient outcomes. Early epinephrine administration is reaffirmed increased ROS and survival as class 1 level of evidence B, but uncertainty about the neurological outcomes. In several randomized trials, vasopressin did not prove to be superior to epinephrine either alone or in combination with epinephrine. The clinical effect of epinephrine is regarded as that equivalent to that of epinephrine. There was a new concept under investigation with the use of a combination of drugs during vasopressor requiring cardiac arrest. There was an RCT done in hospital cardiac arrest demonstrating the combination of the vasopressin, epinephrine and methylprednisolone during CPR and a stress dose of hydrocortisone in post-resuscitation shock that improved the survival to hospital discharge compared to that of an epinephrine alone. Despite the promising results, the additional studies are needed before the recommendations can be made about the combined vasopressors. As you all know, the atropine has been removed from 2010 AHA guidelines for CPR and ECC, ACLS cardiac arrest algorithm in view of its lack of efficiency and is only indicated in cases of bradycardia. So what about the perimortem cesarean delivery? It is defined as the birth of a fetus after maternal cardiac arrest, most commonly during resuscitation. The review of all published cases of perimortem cesarean delivery showed that there is a maternal survival benefit of in 19 to 60 out of 60 cases up to 31.7%. And there was no cases in which the PMCD may have been deleterious to maternal survival. The purpose of timely perimortem delivery is about twofold. It's because the cardiac output that has not been effectively established relieves the iotocaval compression by emptying the uterus, significantly improves the resuscitation efforts, and the early delivery of the baby, which is the second patient, is accomplished with a decreased risk of permanent neurological damage occurring from anoxia. In situation in which the mother is non-resuscitable, example in case of severe trauma, the timely delivery of fetus becomes essential. So the recommendation of PMCD, that is perimortem cesarean delivery, should begin at 4 minutes to effect delivery at 5 minutes after failed resuscitative efforts. So that doesn't mean that it says, the recommendation says, that means that you don't consider it after 5 minutes. You still consider it depending on the situation. To minimize the risk of the neurological damage, which begins to develop after 4 to 6 minutes of anoxic cardiac arrest if there is no ROS, the recommendation says that the institution should create a point of care checklist to help and guide and support the critical interventions during obstetric cases. So here is a point of care checklist that deals with all the circulation, chest compression, airway, breathing, defibrillation, and extract fetus, the major points and the timings that I already discussed. It becomes important as we don't miss any step or miss any important aspect. And here comes the immediate post-arrest care. So what is the recommendations? So if the patient is still pregnant, she should be placed in full left lateral decubitus position and the manual left uterine displacement should be maintained continuously. The patient now can be transferred to ICU unless an operation is required. There should be a pre-event planning for one more arrest should be ensured as discussed above. And the multidisciplinary care must continue. And the cause of arrest should continue to be considered and treated accordingly. All falls under class 1 and level of evidence C. And what about the antiarrhythmic therapy post-cardiac arrest? So you can think of an implantable cardioverter defibrillator, or you can continue the antiarrhythmic medications therapy. And for long QT syndrome, beta blockers are highly recommended during pregnancy and the postpartum period. If there is a recurrent primary ventricular tachycardia and ventricular fibrillation, amiodarone should be considered. And you should as well evaluate for the reversible causes of cardiac arrhythmias, rule out thyroid dysfunctions, any adverse drug effects, electrolyte disturbances, or a cardiac ischemia and heart failure. And a little bit about the targeted temperature management or a therapeutic hypothermia. There is a positive results of 2 randomized clinical trials published in 2002. On the basis of this, the temperature management to 32 degrees C to 36 degrees C to be given for 24 hours, followed by a 36 to 37.6 degrees Celsius for 72 hours has been recommended for a non-pregnant comatose adult patients with ROS after out of hospital. Now even they say in hospital ventricular fibrillation arrest. It is the same for out of hospital or in hospital cardiac arrest once the ROS is at 18. But the data for hypothermia in pregnancy are scant. The pregnancy is thus not an absolute contraindication to target temperature management. However, given the lack of data on the use of target temperature management after perimortem cesarean delivery, the risk of impaired coagulation during the lowering of systemic temperatures, the TTMs may be considered on an individual basis. The fetal monitoring should be performed throughout the targeted temperature management. And what about the medico-legal consideration? The recommendation says all cases of cardiac arrest and maternal near miss should be reviewed by maternal cardiac arrest committee for the hospital. The identified deficiencies should be corrected. All stakeholders or specialties involved in maternal resuscitation should form maternal cardiac arrest committees within each institution to ensure guideline implementation, training, and institution of mock code drills. And there should be a periodic multidisciplinary drills may help institution optimize safety systems. The specific courses on maternal resuscitation should be available to staffs if not available outside a local institution. The future goal should be to have a national and international programs in maternal resuscitation. And there should be a central registry of cases of maternal near miss and cardiac arrest with the documentation of both process and outcome that to be established. And a standardized training course in maternal resuscitation should be developed. Thank you.
Thank you, madam. Any questions towards Manjula ma'am, please?
Madam, it was Dr. Manjula, quite a
Yes,
nice
sir. Thank you, sir.
Indeed, when we talk about the CPR in pregnancy,
Yes,
the most important thing for us is to remember the anatomical and physiological changes which are specific to pregnancy.
pregnancy. Yes, sir.
That's the one thing. And the one common thing you said is there is not much of a difference when we talk about the adult CPR AHA guidelines when you
Yes,
apply
sir.
to pregnancy. And
Yes.
I'm happy that you highlighted the important ones which many of our colleagues would normally forget. So in the sense, what I knew, and of course I could recollect now, is the left uterine displacement per se.
Yes, sir.
So it's not like we tilt the table, which we normally discuss with respect to routine management during transport and during anesthesia and surgery. Tilting would definitely interfere with an efficient cardiac compression.
Yes, sir.
Yeah. So basically, a manual displacement
Is a better option. Yeah, it's better to be considered over tilt.
So that's
Yes.
one important take home for the postgraduates and of course our obstetrician colleagues also. So manual displacement will be very helpful so that we can effect a better success rate in terms of the cardiac compression. And in fact, I think a table tilt or a tilt of the bed, normally we talk about 30 degrees,
Yes.
right? So I think there are some recommendations and guidelines on CPR in pregnancy where they say that about 15 degrees of tilt,
Which has the same.
has
the same. Yeah.
Yeah. Right.
Has the same amount of this one effect with the 30 degree. You need not tilt the table to a 30 degree. That's what this says.
So lesser degrees of tilt would be okay.
Yeah.
At least theoretically speaking, instead of 30 degrees. So at least never try for that so-called 30 degrees tilt for cardiac compression. So that's very important. And promote a manual displacement. So as you said, a single hand management and somebody standing on the left side, tilt the uterus to the left side. That's another important thing. And you are suggesting about the upper extremity intravenous access being better than the lower extremity access, right?
Yes, sir.
So that we don't normally talk in non-pregnant patients, mainly because of the concern about the Myometrial compression.
Yes, sir.
Right?
Yes,
so,
sir.
No, is it that when we do a physical displacement, manual displacement, this concern would slightly come down?
Slightly come down, yes, sir.
So
depending on the effectiveness of our displacement.
Displacement.
If you think,
That's another important thing.
Yes.
And would there be some application of extracorporeal support in cardiac arrest in pregnancy? Of course, we will never have time because even perimortem cesarean delivery, you said we have only 4 + 1 minute, right?
Yes, sir.
Basically.
Yes, sir.
So, but what we discuss as extracorporeal
Membrane oxygenation, ECMO.
membrane oxygenation and intervention in non-obstetric patients, it's purely theoretical, right? In an obstetric patient, would it be possible, practically speaking?
It's difficult, sir, but in centers where they regularly do it, or because first of all, maternal cardiac arrest itself is a very rare condition, and it has to be, as you said, that has to be immediately attended, and it takes time for ECMO. It doesn't happen like that, and to get into the ECMO and go off pump again when that consideration in a pregnant patient with maybe it can be considered after this one, sir, cesarean delivery or something.
Yeah,
maybe
if there is some
Ross is achieved after a perimortem cesarean delivery, can be considered after that. Not very sure about it. Yes.
So, Dr. Kousalya, we have some small input on extracorporeal support, ECMO or something.
ECMO can be given in pregnant patients also, sir. There are 1 or 2 the literature reports also on ECMO being done in pregnant patients. The thing is, if usually we within 5 minutes anyway we do the perimortem cesarean delivery. So perimortem cesarean delivery is for the mother, not for the baby anyway. So once it is done, immediately the patient can be put on ECMO. Main problem with the ECMO is this patient must have had a surgery. So we have to be very careful about
bleeding.
Okay. Dr. Manjula, you have a good skill lab, right, in Enopoya?
Yes, sir.
So, like, do you have this resuscitation related training obstetric department also?
Yes, sir. We do take a resuscitative programs even for the obstetricians on a
Maternal
regular
cardiac
basis.
arrest.
Maternal, no, sir.
Okay.
Not really.
It could be one which could be very useful. After all,
Yes,
it is a team effort, as you said.
Yes, sir.
Among us and the surgeons and the neonatologists and other group.
Yes, sir.
We asked with respect to.
Yes, sir.
Dr. Manjula,
Yes, sir.
it was a very informative presentation. Sometimes,
Thank you, sir.
as soon as we start the case, that is after induction or after giving subarachnoid block,
Yes.
we'll land up in some pre-arrest like situation, like extreme hypotension or bradycardia.
Yes,
We'll be continuing the resuscitation. And what should be the role of obstetrician at that time? Whether they have to hurry and do the surgery and deliver the baby, or they have to wait till the patient is stabilized?
It's a tricky thing, sir, to ask, because it should be simultaneous. So what we have to do is we have to look after the hemodynamics. So usually what we have noticed is unless they have a cardiac conditions, if the blood pressure is not regularly monitored, if there is a little bit of time lag between the giving the subarachnoid blocks, there is a sudden drop in hypotension if there is no wedge or there is no displacement, or secondary to the subarachnoid block complications. So we should try reviving, like get the hemodynamics by either co-loading the patient or giving the vasopressors, like we give ephedrine to the patients or mefentramin to the patients, and get the blood pressure under control. If there is a brady, again atropine, and once it is controlled, and I think that simultaneously even the cesarean section should go on. If you feel that there is something wrong, you can ask the obstetrician to wait. If she has not put an incision and you have witnessed, you can wait for some time till the hemodynamics come under your control.
Good evening, Srinivasul, sir.
Yes, sir. Go ahead.
Hello, sir.
Go ahead.
Sir. Regarding especially obstetric anesthesia, what has to be stressed on supine hypotension syndrome. Actually, that was been discussed in a very good way. But apart from the left uterine displacement and the lateral tilt of the table. I would like to add one more point, sir. Keeping a wedge under the right buttock of the patient,
Right.
so that especially during resuscitation, you can save one hand, one patient, one resuscitator, so that he will be helpful for resuscitation or any other airway management or other thing. If you keep a wedge under the right buttock, it will be almost equally effective as lateral uterine displacement or lateral tilt of the table. That I would like to add, sir, with the permission.
Yeah.
What do you say, madam?
Uh,
Manjula, madam?
So that's what is normally practiced, but it is not mentioned anywhere to keep a wedge under the right buttock. But that's what is normally we normally do. We don't say the obstetrician that. I think we should start saying the obstetrician. You displace the weight manually to get the thing, but they will be so engrossed in the cesarean section. So we ourselves keep a wedge under the right buttock to prevent the supine hypotension. So how effective it is over manual uterine displacement, I don't know about it, sir. If you can compare it as equal to that.
No, especially during
Yes.
resuscitation, madam, because one
Yes,
person
sir.
we can't engage in just lateral uterine.
Yes, sir. We can do that, sir. Yes, sir.
Yeah. Dr. Kousalya?
Yes, sir. Can I give my inputs?
Yeah.
Yes,
Sorry, right.
First of all, I want to answer the previous question, sir. When we have given a cesarean section and something happens to the mother, so we have encountered 2 or 3 complete cardiac arrests on table. So in such conditions, first the obstetrician has to deliver the baby. That is very, very, very important, sir. Whatever resuscitation we are doing on the head end, the obstetrician has to deliver the baby. Whether the patient is scrubbed or not doesn't matter. First, the baby has to be delivered. Then only the mother will come out. And we had encountered 2 cases like that. One when as soon as we gave spinal, she was a twin gestation. As soon as we gave spinal, the patient collapsed. So the twins were delivered, both the twins were alive, the mother was alive. So we always have a hesitation whether we should resuscitate the mother first or whether they should do the section. And even the obstetricians have an hesitation whether they should put a knife or not. So in such conditions, on table, everything will be ready. So they have to deliver the baby and we have to intubate the patient and then put the patient on ventilator later on. That is one thing, sir. And second, about the wedge, sir, Subramaniam, sir, whether we should put a wedge under the right hip or a manual uterine displacement. If it is only for a supine hypotension, a wedge will do. Because the patient is not arrested, patient is completely cardiovascularly, patient is stable. Only thing is a supine hypotension. So if we remove the uterus, the patient will be okay. But in case of cardiac arrest, they are advising not to put a wedge under the right hip because the patient will get tilted. That will decrease the efficacy of giving the cardiac compressions. So cardiac massage has to be given in a correct supine position at the exact place. And the uterus has to be displaced manually. That is why it is known as manual MLUD, manual left uterine displacement. That is the recent guidelines. No tilt, no wedge, only manual left uterine displacement. That to lift and then shift.
Yeah, that's the most effective one, doing a manual displacement.
Yes, sir.
And in fact, getting other evidences, if you have, all of us have observed during Dr. Manjula's presentation, and all the AHA document. The recommendation will always come as, they say it's a class 1 recommendation, but level of evidence is C. So we don't have much evidences, but it is inherent to this condition. We never will have any randomized controlled trials related to cardiac arrest. So we have to depend upon some of the small observations which are made and published. So the level of evidence will never be that much, but the recommendations have to be made. Mainly keeping in mind basically we are talking about getting the patient's life back.
Yes.
So that way the current evidence and the AHA says manual displacement. Yes, ideally to follow that manual displacement. And for as Dr. Kousalya was telling, for routine management during shifting and during cesarean section, talking about a wedge is very good. There is no problem at all per se. But here it's a matter of time and life and death. And as Dr. Srinivasu was telling, it's quite a common place to think about asystolic cardiac arrest, especially in obstetric anesthesia. So we have encountered it, and if it is purely asystole, it is very easy for us to manage the patients, fortunately. Sometimes it is easier to manage the cardiac arrest in obstetric patients, mainly because if it is related to bleeding, the simplest thing and earliest thing to do would be to replace blood with blood. Yes, it's Dr. Kousalya and Dr. Manjula. So if it is related to the bleeding disorders of pregnancy, for whatever reason, if you are able to replace the blood in time and in the sufficient volumes, we are able to retrieve the patient.
Yes,
So,
sir.
yeah, the other extremes are there. Embolism, we talk about the thromboembolism and amniotic fluid embolism, where we have got definitely less scope for successful resuscitation of the patient.
Yes.
Yeah.
Yes, sir.
There is one more question.
That is the same question by Dr. Srinivas, sir.
Yes, same thing.
No,
Yeah.
there is
Question is
when
asked.
you are suggesting PMCD, is it worth delaying the cardiac cesarean section for pre-arrest? Standard recommended Crawford wedge for OR dimension will not compromise the resistivity efforts. Okay. Samsung, I don't know who is the person, colleague who is asking the question. Who is this? You can just unmute
Unmute and ask.
please ask. Yes.
Good evening, sir.
Yeah, please. Welcome.
It's me.
It's
Carol.
the next.
Good evening, sir. Sir, you can ask
There
the
are two
question.
things which I felt that if we are talking in terms of peripartum cesarean delivery, I don't think we should wait any longer if we have an event of pre-arrest or an arrest after regional anesthesia for a cesarean section. No question. Just proceed with the cesarean. You have a highest chance of reviving this patient. Point number one. Point number two, if we are using about the wedge that we are talking about, there are two different wedges. One is recommended for the labor table. The other one is for the OR. The OR one, they have got specific dimensions. If we go back to the Crawford textbook on obstetric anesthesia, we've got the specifications on that. We're using them exactly 15 degrees tilt will not compromise any resistive effort. It is slightly placed, it will not. What is happening most often is that we use anything and everything that is available for us to use as a wedge. That is where we have displaced and distorted the anatomy. That is what is going to cause the problem. Of course, I mean, if somebody is trained enough to do a proper lateral displacement, manual displacement, yes, it's very good. If somebody is not trained, probably it's more harmful than a wedge.
Yeah, agreed.
Okay.
Yeah. Ultimately, it's the resuscitator who should be, producing the best type of compressions and displacement. That's most important aspect. So a table, an expert assistant. So these are factors which could help in an effective resuscitation. Thanks a lot. So
I don't see any more questions here, sir.
yeah, okay. So we had. It was a quite comprehensive presentation.
Thank you so much, sir, for giving me this opportunity. Thank you, ma'am.
Thank you.
Thank you.
Thank you. Thank you both for the.
Okay, there is some last
presentation and
question. I think it can just take and then we can come to the end. PMCD with an IUD.
In intrauterine death, no, so it's intrauterine death, PMCD in intrauterine death.
In intrauterine.
For mother resuscitation, for maternal resuscitation rather than the fetal.
Yeah, yes.
That's
Because PMCD is basically the to relieve the aortocaval compression so that mother can become, if after all the efforts it's not working, I mean PMCD as early as possible, it's for the mother, maternal resuscitation.
Okay.
Thank you, sir.
Thank you, Madam Kousalya, Madam, and Dr. Manjula. It was an interactive and an interesting session today because it went on for almost 2 hours. Thank you, Madam. We thank you.
Thank you.
Yeah, ma'am.
Thank you, all of you, madam.
Thank you.
Thank you, sir.
Dr. Subramaniam is incidentally our colleague from Anandpur Medical College.
Anantapur.
So thanks for an active participation.
Thank you, sir. Thank you.
Thank
Yeah,
you, sir.
we hope to have further academic interactions with both Dr. Kousalya and Dr. Manjula in the future also.
Sure.
Sure, sir.
Thank you. Good night from me.
Thank you, madam. Good night.
Thank you, sir. Good night.
Sir.
Thank you.